Thank you for having me here. So my connection with cerebral palsy goes back a long way. So I worked with. But just hold on 1 minute.
ये जाएगा ना दोबारा कभी कम हो सकता है मैं छेड़ भी नहीं रही हूँ
Mrs. Gurkar, please move.
So my connection with cerebral palsy goes back a long way. During my early years of training, I used to work with Professor Benjamin Joseph, who had the first multi-speciality cerebral palsy clinic in India. So, and with the Gate Lab, this was 100 years ago. I think things have changed a lot since then. I don't see cerebral palsy patients myself, but patients requiring surgery.
बॉडी को तो चाहिए नींद
Mr. Gurpreet, please mute yourself.
Patients requiring surgery are actually referred over to our spine center.
Sir, I would request if you can mute. I think so. You have an option. Can you mute everyone?
Okay, one sec.
You will see.
You can take control from me. You can take control from me. I can continue with my talk.
Okay. So then you can just make me host.
Sure.
Do I have... Can you the co-host?
Siamo andati lì, sta facendo una conferenza.
Sorry, I'm not too sure how to do that, Kanu.
Sir, just click on my picture. You will see option.
Yeah.
You will see make a host on my profile. You will see that on
make host.
Yeah. Click on it. Yeah, perfect, sir.
Yeah.
Thank you.
Okay, are we good?
Oh, perfect, sir. Perfect.
So, okay. So I don't see any cerebral palsy patients myself in the clinic because I'm not involved in the primary care of cerebral palsy patients being a spine surgeon, but they are referred to us by my orthopedic colleagues and others and physiotherapists who treat patients with cerebral palsy, and predominantly sent over to us when they require surgery. So I really don't have to do much thinking about it. So I go by what my orthopedic colleagues decide on. If they say, I think this patient requires scoliosis surgery, we just go ahead and do it because, so my job in cerebral palsy spine care is predominantly technical. So I just, just do what I'm told. So it's interesting that we're talking about scoliosis this month. June is Scoliosis Awareness Month, and it's important, whatever part of physiotherapy you're dealing with, to pick up kids with scoliosis early because of cerebral palsy or any other condition also. Because as physiotherapists, you definitely spend more time with these children than the medical specialists do. So coming to what is scoliosis? So the normal spine is straight when you look at it from the back. Scoliosis is defined as a sideward bend of the spine more than 10 degrees. It could be structural, wherein the problem is in the spine. The spine itself has become stiff in that position, or it could be non-structural because of a limb length discrepancy or a disc herniation or even hysterical scoliosis. So the causes of scoliosis are many. The congenital scoliosis is one of them. Congenital scoliosis is that type of scoliosis where there is a congenital anomaly in the vertebrae and either an extra vertebra on one side or what is called an unsegmented bar, or the vertebrae are not divided completely on one side. That results in disproportionate growth between the two sides of the spine, resulting in a scoliosis. That's congenital scoliosis. There is the bigger group that is referred to as idiopathic scoliosis, and these are kids for whom we don't know the exact cause of the scoliosis. And then comes neuromuscular scoliosis, under which cerebral palsy comes, and we're briefly going to discuss cerebral palsy, scoliosis associated with cerebral palsy today. So why does scoliosis develop? There are lots of reasons why scoliosis develops, because of the spasticity. There's some muscle weakness, there's some incompetent muscle control, poor balance, sometimes dislocated hips, you know, flexion contractures of the knee, causing the patient to lie to the side, causing some, you know, pelvic obliquity, can cause start off this process of scoliosis. The risk of developing scoliosis has been looked into. It's directly proportional to the level of the GMFCS. So grade 4 and grade 5 GMFCS are associated with a high incidence of scoliosis. 75% of them eventually have scoliosis. Girls develop scoliosis more than boys. Kids with epilepsy have a higher risk of developing scoliosis. Kids with dislocated hips and the windswept hips can develop scoliosis. Kids with limited knee extension can also develop scoliosis. These are the, you know, 5 causes, 5 risk factors for scoliosis that have been looked at in a multi-analysis. So this is the graph that shows the percentage of kids who will develop moderate to severe scoliosis depending on the GMFCS level, and you can see the bars on the right side where, you know, GMFCS 4 and 5, there is a high incidence. You see the gray color bars, there is a high incidence of moderate to severe scoliosis in more than nearly half of these kids. So, and it's also important to remember that the scoliosis in cerebral palsy differs from the scoliosis in idiopathic scoliosis, differs from the curve in idiopathic scoliosis, the one that we see more often, in many ways. Number one, the curves become progress more rapidly, the curves become stiff more rapidly, and the curves can progress into adulthood. These things rarely happen with idiopathic scoliosis. So the curves in idiopathic scoliosis, so the more common kind of scoliosis that we see, don't actually progress too much after the age of 18 unless the curve is quite large. But kids with scoliosis, progression can occur right into adulthood. So it's important to remember that. 2 types of curves that you see. There's this type 1 curve predominantly seen in ambulant kids. This is quite similar to the curves that is seen in idiopathic scoliosis and the other type of scoliosis. And the group 2 on the right is the large C-shaped curve, which also results in a pelvic obliquity. And these are more common, as is obvious, in non-ambulant kids. So does scoliosis worsen? Scoliosis does worsen in kids with CP. So if the Cobb angle, that's the measurement of scoliosis, is more than 40 degrees, it is very likely to progress. Smaller curves can also progress. Progression is not confined to the pubertal growth spurt like in idiopathic scoliosis, so they can progress into adulthood. More rapid progression is seen than idiopathic scoliosis, like I mentioned earlier, and they can progress into adulthood. So I think, you know, you need to look at these kids from the point of view of scoliosis for many reasons. It definitely affects their quality of life for one. So there are lots of ways of managing scoliosis. There's sittings. Non-surgical management is the aim of non-surgical management is to preserve functional ability. So sitting supports and bracing is something that should be done, but it really does not have any significant effect on curve progression or the final outcome. So sitting supports, I'm sure all of you are more familiar with it than I am. So it improves sitting balance, some lateral chest supports, modified back support to accommodate kyphosis if it does occur, but doesn't have any effect on the natural history of the curve. And the spinal braces may buy time till surgery is done in kids, in younger kids, but there's always issues with compliance, skin problems, feeding problems, and because they go encircle the chest wall, there can be respiratory issues too. And so compliance is a major issue. Compliance in idiopathic scoliosis is a big problem, but compliance in brace compliance for kids with cerebral palsy is a bigger problem. So that leaves us with surgery. So who exactly requires surgery? So surgery is an option in kids with curves more than 40 to 50 degrees. That's a Cobb angle more than 40 to 50 degrees, who are over the age of 10. They also in kids with poor sitting balance. So the minute they lose their sitting balance, they tend to use their hands for sitting to support them while sitting, and then, you know, there's significant functional loss with that because then they're left with only one hand to do things with. And if there's a deterioration in the level of function because of the curve, so that's when you can think of surgery. And the aims of surgery are, number one, to stop the progression of the curve. Surgery definitely improves the spinal alignment, so they can improve their sitting balance. So the aim is not to correct the scoliosis and make the spine straight, but to get a level shoulder and a level pelvis, so that sitting balance is improved. Surgery does improve respiratory function. Surgery can reduce pain in kids with severe scoliosis who have costopelvic impingement. So the lower ribs can hitch on the iliac crest and cause a lot of pain in kids. So surgery to straighten the spine can help with that. Surgery can reduce pressure sores. Kids with pelvic obliquity have excess pressure on those areas on which they are sitting, and trying to get a level pelvis and level shoulders and good sitting balance can reduce the incidence of pressure sores. And there are lots of studies that have shown that it does improve the quality of life. However, word of caution, you need to assess the risks with the benefits. There are kids who are sick. There are kids who are not medically fit to have surgery, and probably will not benefit from surgery, or surgery may be quite risky in these kids. So that's why since I see these kids only when they come in to see me, and is being seen by my orthopedic colleagues at other times, so they have a better idea on how these kids are progressing, and they decide on who requires surgery and who doesn't. So the kids are actually divided into two big groups, those below the age of 10 and those above the age of 10. So it's important to remember that the first decade of life, there are lots of things happening inside. So there is this whole issue with increasing lung maturation. So increase in the number of alveoli. So you can see this graph marked in blue. So you can see that there is till the age of 4 or 5, there is an increase in the number of alveoli till it comes to normal. There's an increase in the lung capacity that occurs, this blue line. Increase in the lung volume. So that goes up. So till the age of 10, we tried not to offer them any surgery that like the traditional fusion surgeries. We try to offer them something called growth-friendly surgeries. These allow the chest to expand and the lungs to mature. So somewhere here by the age of 10, so after the age of 10, most of the alveoli are formed. The lung volume is sort of close to normal. So anytime after the age of 10 to 12, may be a good idea to do surgery. If you're doing surgery in younger kids, then it cannot be the traditional fusion surgeries, and you need to go in for the growth-friendly surgeries. So I'll show you some examples of growth-friendly surgeries. These are called growing rods. So this is the old type of growing rod. So you have two rods parallel to each other with a cross connector here, and then every 6 months this needs to be loosened out, and then the rods extended a bit, give it a little more length like that. So 6 monthly small surgeries, they're daycare surgeries to lengthen for rod lengthening. So that will keep up or help the chest wall and the spine to grow as the child grows. So that is the growth rod surgeries. So this requires 6 monthly surgery. So some of the kids may not be, especially some of the CP kids with cerebral palsy, may not be ideal candidates to be taken back to OT every 6 months if they have lots of other medical comorbidities. So this is a Vepta, I leave that. So there is this new device come out where the rods can be lengthened with a magnet kept outside the body. So these are implanted during surgery, and the lengthening can be done with a magnet that looks like that outside the body. So that is the same kind of concept as the growing rods, but these are magnetically controlled growing rods. Become very popular. Been some issues with implants recently. There's been some FDA callbacks on this. So I haven't used this the magnetic rods. What we use is something little different. It's called the Schiller technique. So this boy is 6 years old, and he had a bad curve. So not cerebral palsy, but you know the surgical technique for kids with cerebral palsy is nearly the same as this. So I'm just showing you some non-cerebral palsy kids surgical pictures. So this is post-operative, 6-year-old, bad curve, more than 60 degrees, and severe truncal imbalance. So what we did for him, so he's too small to have a traditional fusion surgery. So what we did for him is something called the Schiller technique. So wherein you can see that he's had a front surgery also. So you can see a scar here where I'm pointing to. So we've gone in through his chest wall, gone in there, and at the apex of the curve here, we've removed the discs and put some bone graft in so that it just the apex fuses up. Then we've gone in from the back again, put screws in here at the apex, and then screws above and below. Now the screws at the apex are tightly fixed to these rods, whereas the screws above and below are loosely fixed to the rods. So these allow the rods to slide through. So the child continues to grow, but in a railway track kind of path. So it cannot, the scoliosis is controlled, but it allows the child to grow. So these rods allow, these screws allow the rod to slide through. These screws allow the rod to slide through, and these are fixed. So this is the Schiller technique. This boy is around 2 or 3 years down the line now. He's grown by around 15 centimeters, less than 3 years, sorry, 2.5, I think. But he's continuing to grow and maintaining good balance. Whereas children over the age of 10 to 12 years, you can do the traditional fusion surgeries, which involves putting screws and rods at multiple levels and then connecting it with rods. So I show you some examples. This is a 10-year-old girl with scoliosis. You can see bad curve. Looks much worse on the X-ray than it looks on her. But just 10 years old, we fused her, and this is what she looks like now. So these kids stay in hospital for 4 to 5 days. They're out of bed and walking in 2 to 3 days. So we give them what is called the 5 to 6 rule. The 5 to 6 days in hospital, 5 to 6 weeks before they go back to class or go back to school, and 5 to 6 months before they take part in very aggressive sporting activities. So this is a 10-year-old girl. I'll show you another one. This is a 16-year-old girl. You can see she's got a bad curve, around 75 degrees. 10th or 11th standard, I think she was in when she saw us. Definitely was getting worse, and she was very unhappy with the appearance. And that's how she looks like now. So multiple screws and rods. You can see that the shoulder levels are nearly the same. She's got nice waist symmetry. You can see that as compared to this, you can see that the waist is completely asymmetrical here, and she looks clinically very good here, and the X-rays are looking satisfactory also. So it's a 16-year-old girl with scoliosis. These are all predominantly AIS, but like I was saying, the technical part of the surgery does not vary much, except that if the patient has got pelvic obliquity, we tend to put some screws into the pelvis and fix it up. And that really doesn't affect their walking ability much. So this is another one, much bigger curve. You can see that it is more than 120 degrees. Little older girl also. I think she was around 19 when we operated on her. And yeah, so these big curves come with some risks, and she was very small built, and so what we did was we admitted her for 3 weeks in the hospital and gave her some halo traction. So we put a halo ring onto the head, put some pins into the skull, and then gave her traction, the weight being around half of her body weight. So she was on traction in bed. She was on traction while sitting during the day. We put her on the treadmill for at least 3 hours a day, 1.5 hours in the morning, 1.5 hours in the evening, with traction that went through her skull. So she was basically being pulled up that way, and then at the same time we tried to improve her respiratory function, lots of spirometry and breathing exercises, and also improved her nutrition, so high protein diets and all kinds of vitamins and minerals and things like that. And then 3 weeks later she underwent surgery, all from the back, and this is how she looks now. So she's come out pretty she's pretty happy with the outcome, although she had to stay in hospital for long periods of time, but she felt that it was well worth it. So just to show you that all kinds of curves can be corrected with surgery. And the only problem is we don't see much cerebral palsy kids with scoliosis. In my clinic I've seen a lot of cerebral palsy kids with scoliosis, but I rarely see any cerebral palsy kids in my clinic, because I'm sure a lot of parents are reluctant to put them through surgery, to a big surgery, and there are certain risks associated with surgery in cerebral palsy and other neuromuscular conditions. One of them being infection. So the normal rate of infection in a standard traditional fusion surgery like this is around 1 to 2%, whereas in cerebral palsy and other, especially with low GMFCS levels, the infection rate can go up to 7 to 10%. So that is an issue. And depending on the GMFCS levels, you're dealing with issues with nutrition, you're dealing with issues with seizures. Feeding is an issue with a lot of people who have some swallowing problems. So if they have surgery, all these things need to be taken care of. And yeah, that's the end of my talk. If there are any questions, I'm willing to take them.